President of Health Tech Strategies in McLean, Virginia, and we're a consulting firm focused on health IT and telehealth and remote patient monitoring kinds of things here in DC, and as such have held more than 200 plus lunch briefing sessions and technology demonstrations here on the Hill, all focused on telehealth and IT health issues since 1993 for groups like HIMSS and ATA and all sorts of folks. I'm kind of like the Stephen King of holding programs, and I never know from one to the next what it's about, although I do know that this is by far and away the most serious and important thing we could possibly ever focus on. The issues are insidious. It's inherently, obviously destructive to so many folks and their families, veterans and their families, and something we probably should have dealt with long before this. We've done many with the DOD, with Army Patrick, and with the Veterans Health Administration, when Dr. Darkins was clinical care coordinator over the years around telehealth programs and things, but not on this specific issue. That said, because we have such a stellar lineup of panel, I'm going to stop and not talk at all about something I know nothing about and leave it to folks who do. But first I want to thank our colleagues who helped co-sponsor the event, the ACT, the App Association. Where's Grant? Grant, he'd like to talk just a little bit about what ACT is and the Connected Health Alliance and things that they're working on. We have a multi-stakeholder group on telehealth that we're all involved in through them. So why don't you come on up here? Congressman Bergman's going to be here at or around 5 o'clock to welcome you, and by then we'll probably be in the back of the room having a glass of wine or cheese or something. So, Graham, why don't you take it away?
Well, thank you, Neal, and I just wanted to say thanks to everybody for coming and joining us for this briefing. Thanks to the panelists. ACT, the App Association, is a group of about 5,000 different software and tracking device companies. We run what's called the Connected Health Initiative, 190 organizations, and a steering committee of about 15 different organizations, including University of Mississippi Medical Center, UC Davis, AT&T, Qualcomm is along with us as well. And we advocate for basically the policy changes necessary in order to adopt technological platforms, whether it's telehealth, telemedicine, or software platforms that can be useful for doctors, patients, and for government services. So thanks again to everybody for being here. We're ACT, the App Association's actonline.org, and connectedhi.com is our Connected Health Initiative website. I urge everybody to take a look there. And I'm thankful that everybody, since we kind of rowing in the same direction here, on veterans healthcare especially, and I'm glad Dr. Carroll is here, really led the way in the use of telemedicine and collecting the data that shows that it can be useful, that it can be helpful for patients, and that it can cut costs after all, unlike CBO's views. So I'm really appreciative that the panel is here and that everybody's here, and glad I got to help out with planning the event. So thank you.
Thank you. Thanks so much. Thanks, Brad. Okay, so, and again, I want to thank Congressman Bergman's office, Amelia from Congressman Bergman's office. Some of his staff are going to be down later also with us. With that, and without further ado, you have all of the bios, I believe, in the packet that you handed out in the front. So let's not get into any of that. You can read them at your leisure, and we're going to go right down the line. We always start with our federal officials, and we have two key current federal officials right here on this topic. Dr. Keita Franklin, who's a member of the FCS, is Director of Defense Suicide Prevention Office, and is responsible for policy oversight for the department's suicide prevention program. So, Dr. Franklin, take it away. What we're going to do is maybe have each of our speakers talk, 5 to 8 minutes or so, and then have a free-ranging discussion, hopefully involving all of you. And if there are no questions, I will call on you to pose questions. And Wayne Humphrey knows I will.
Yes, he will.
Thank you.
Thank you so much. I'm happy to be here this afternoon to provide a bit of an overview on the DoD suicide prevention efforts with a specific eye towards IT or technological solutions, and thought I would just begin with a little bit of framing on the office and what the DoD is currently doing, what's currently underway in the suicide prevention space. So it couldn't be more better timing in light of the fact that it's Suicide Prevention Month, and we're doing a number of initiatives across all the branches of the military service and right there in the Pentagon to try to highlight consciousness raising around the issue of being there and trying to take action on behalf of suicide prevention. So that being said, just in the way of getting us started, I want folks to know that we do have a departmental strategy for suicide prevention. I won't sort of walk you through or bore you with all the details, but know that it is on our website, www.dispo.mil. This strategy, why it's important is because it really lays our path or our roadmap for how we get after suicide in the DoD. It was built off of the national strategy, and after probably 18 months of staff work and getting all 4 branches of the military on board, which is sometimes not an easy feat, getting consensus across all the branches in light of the fact that there are some cultural differences within each, getting them to sign off and agree to this path where we collectively have 13 goals and 69 objectives that literally lay out what we call our public health approach to suicide prevention. And what that means is that we've really shifted in how we're looking at suicide, and we're no longer thinking about it as strictly a medical problem or a mental health problem, but more of a broad sweeping problem that really puts military line leaders at the center of the prevention effort. And so I say that because it will make more sense later on in my talk when I get around to IT solutions for the community, or IT solutions for line leaders and not just medical health professionals. And certainly every capability equally is important when we're trying to get after the fight on suicide. Within the department, we think about our suicide prevention efforts consistent with the Institute of Medicine's model for prevention and the continuum. So we offer capabilities to universal populations. You see things like troop training, everyone gets it. We put them through it. We try to make sure it's evidence-based and focused on getting them out of their duty stations for the shortest amount of time with the right curriculum that's tied to making sure they know how to take care of themselves and take care of their peers and take care of their family as it applies to risks for suicide. But we also try to chase down those that are not just universal, but those group populations that are also at risk. And so we do have some. We have, whether it's MOS populations or unlike our civilian data, which you may hear about from some of the other counterparts here on the panel and or even in the VA, our at-risk population is 18 to 24. Largely the most percentage of folks we have on active duty. So male also, but we try to look at what our data tells us for what groups are at risk, and then we think through capabilities and interventions for groups. And then also individuals, so universal, selected, and indicated, and making sure that the capabilities exist across communities and units and states and the like to make sure that it all sort of maps together and we have a comprehensive approach to our efforts. So with that in mind, our key number one partner right out of the gate is the VA. And why that becomes important is because one of the highest risk groups are those that are transitioning between any types of transition, but particularly of interest right now to our secretary, and I'm probably rightfully so to say the secretary of the VA is helping to make sure that we're doing a good job transitioning service members when they leave the DoD and they enter into other healthcare systems, whether that's the VA or a host of others as determined by the individual. It's a particularly at-risk period because we have good capabilities in place for when they leave the DoD and they have a known mental health problem or a known medical problem. I think there's good and strong capabilities that coach them in warm handoff, probably even hot handoff right into care. But when they don't have a known problem for all the right reasons, perhaps they just don't have one, and then they have a life event that occurs afterward that is particularly stressful, we need increased care and capabilities when those things pop up down the road, whether down the road is 3 months after they transition or a year or 4 years or whatever. So transitioning folks between agencies, if we don't have the right systems in place, I only say this because I know we have some IT folks in the room, and thinking through your IT lens, what a capability or system would look like to help us ensure we have those transitions is critically important. So it's an increased emphasis going on right now in the department. So other than framing and kind of telling you how we get after our issues, what I brought with me was just a number of initiatives that we currently have going on, sort of hot off the press, current stuff that has a bit of a touch to the IT piece. So I'll just rattle through them, and then I'm happy to engage in conversation with any of you about any of this throughout today's event. The first, and I should have said I'm a social worker, I'm not an IT expert, so to the extent that I don't have all my language right around this, please tell me. So we do have an initiative underway where we're partnering with Craig Bryant out at the University of Utah that has to do with social media. I hope some of you in the room have maybe heard about it, but one of the things that we've done recently is taken service members that have died by suicide and had open domain social media platforms and looked at their posts in the last 12 to 24 months leading up to the death by suicide. Hundreds of posts, and we're looking at posts that are going out from them individually and posts where they're engaging with others in conversation. And so we're able to pull all that together and do sort of a qualitative analysis and look for themes. And that's been a new innovative solution set that we've worked with, and there's just been one published article on it so far, and if you pull it, you'll see very simple findings that might not be that surprising to you. You'll see things like the risks actually appearing on the posts. Service members that are writing that they're in legal trouble or financial trouble or unit trouble, command trouble, that they feel isolated and lonely and not part of the group. And it's all listed right there. And you'll see high amounts of pictures of alcohol, and you may even see a picture of a weapon. Any one of the posts by themselves would probably not make you be alarmed or think that somebody were at risk, but when you see the collection of posts over time at multiple touch points, and you start to see negative thoughts and negative emotions and even divorce and all of this play out, you would read the post, as I did after the study was completed. You would know that that person were at risk and right away know that we needed a solution tied to that. Making sure that the peers in the unit and the friends that are on those friends list, that they know what to say, when to say it, and how to intervene. So that's one of our latest efforts that we're trying to even further advance. The study finished, and where we're at in this stage is we are trying to translate the findings into actionable results for each of the services. So what does that look like? Training, you can imagine, right? And trust that I know that training alone is not the solution set by itself for suicide, but we are working with the Army, the Navy, the Marine Corps, and the Air Force on what would this training look like at the installation level, at the troop level, to make sure they know what to say when they see these risks online, what not to say, who should engage, how do you say it, and how do we embed that training into their existing training pipeline, both as part of their annual requirements and then at the schoolhouses as we develop them over time. So for example, an 18-year-old airman clearly needs to know something different about what to say when his friends, vice perhaps a small unit leader or a 25-year Army veteran about to exit the service, who's responsible for a larger group that some of this might be going on. So the translation part is critically important. Other than the social media one, I would also offer, my office is the Defense Suicide Prevention Office. It's called DISPO, but we partner quite a bit, and the DoD has another office. I brought their capabilities with me today just to share them with you, but know that I'm not the process owner over these, but I did want you to know about them because all of you in the IT field may find them interesting. And that is 5 separate apps, and I'll float this around, you can find it online, but it's a capability within the department called T2, Telehealth and Technology. If they were here today, they would, I'm sure, be able to participate in rich dialogue with all of you, but I can take back anything that you may have for them. But these 5 apps and how they have relevance for suicide is important. The first, I won't go into all of them, but I'll just hit on them briefly. The ones that I think are critically important for prevention of suicide. Have anybody heard of the virtual hope box? Just my one close colleague that I'm in contact with all the time. Thank you, Eileen. Virtual Hope Box is a capability. It's an app, but it's not unlike a tool that you would use in therapy, where you're trying to get people to identify reasons for living. So you're looking for protective factors and things that keep people afloat, but the Virtual Hope Box, you actually put them in there, and it's something you can reflect on and go in and journal about. And it's a simple capability, but it's powerful when it's used either by itself. You know, when we're thinking about IT solutions for service members, we're thinking about the I can do it myself mentality, right? Because they can. They want to get into something, they want to access psychoed, they want to push and play and figure things out themselves. And so that's a great capability that can also be used as adjunct to therapy. And then just know the other ones, there's something called tactical breathing and an app around that, self-explanatory probably. Something about breathing and relaxation, again, an app, self-explanatory. An app that is focused on cognitive behavioral techniques that get after insomnia. And so helping you monitor your sleep patterns, your things leading up in the day, days when you have good sleep, bad sleep and the role of sleep in keeping people well. So I'll float this around if folks are interested, and then you can kind of take down the website and gather some more information. I want to shift gears from those type of tools to talk to you a little bit about data. Are there folks in the room that like the data part of the solution set? Are there data science folks? Okay, good to know. Couple different things in the data space. With, the Army is leading the way right now with something called the Commander's Dashboard. So what they found was that they were commanders, young commanders, imagine an 03 responsible for a unit that has a lot of troops there, and they're getting data points from lots of different places, and just how confusing that would be. So they've developed a commander's dashboard, which is sort of a one-stop shop that brings in things like child abuse data, domestic violence, alcohol-related incidents, sexual assault data, attempt data, all into one big dashboard so that commanders can fully assess risk in a one-stop kind of shop. Versus before, it was a pull system from multiple places. Now it's a push system from one place. So they're just in the early stages of executing that across the Army. The other services have some variation, but this is the one that's kind of out in front. One of our roles in the DISPO office is to work with the services on generalizing best practices. So oftentimes we meet with them quarterly in a committee called the SPARC, Suicide Prevention and Risk Reduction Committee, and we have them share best practices so that we can think through how to elevate the whole sum. And the Army has pushed out that capability here recently. Commander's Dashboard, it's called. Otherwise, we do also have a data set that we've done in conjunction with our VA partners. We've recently renamed it. It used to be called the Suicide Data Repository, if that rings a bell for anyone. But it's called the Military Mortality Database. What this is are any of you familiar with the National Death Index, NDI? Thank you, Eileen. I'm so glad you did. So the National Death Index is a data set. It's all-cause mortality of death. So it's not just about suicide, but every reason, and death certificates get funneled into it, and we can track as a nation why people die, from what reasons, and when and how. Well, this data set is owned by the CDC. The DoD and the VA have partnered to take that data and put it in, bring it together with another data set, which is from our DoD data called the DMDC, Defense Data Management Center. So you can imagine how powerful it is if we find out that someone has died by suicide and they're 25 years old, they've been married twice, they have 2 children, they've deployed 6 times. One of those was to a hotspot where we knew this happened and that. You can sort of track all of these military personnel data points with cause of death. In my case, I'm most interested in cause of death related to suicide, and we can track it over time. I want to say the data set's available for the last 14 years. We both pay the CDC to get that data as part of our partnership, but it is available to civilian entities. So if you partner with somebody in the DoD or the VA, and I always tell people, if you don't have a partner, see me and I will find you one, because we don't want that to be a reason to not access the data. Also, if you are interested in digging into the data and finding something, and you're interested in studying it with us, I will also tell you our biggest questions that we would like to dig into it further to identify trends over time. So that's free and available. There is a bit of a process you go through like anything, but I would like it to be streamlined, quick, and not get in the way or become a barrier to good work that has to happen. So that's one database. And then we have another data set, a data report that comes out annually called the DODSR. This is the Defense Surveillance System, where we push out all of our data on suicide and attempts. This is written by this capability I told you about called T2. But if you go on the dispo.mil website, you'll see all the prior year's DODSR data. And those of you that are interested in scrubbing or looking into that data and matching it with other data that you may have available or know about, please talk to us, because we think that the data might be a key and essential part of either informing future IT capabilities or other types of capabilities as well. So we are pretty keen on trying to use it more than we have. We've been very good at collecting it, assessing it, and giving it right back down to our line leaders who need it, but we're not always so good at thinking through broader solutions where we have other partners that look at it and help match it with other type of things going on in the stratosphere that might inform it in a way different than our own lens, if that makes sense. Otherwise, I would just share that we do have a study going on right now with the Marine Corps about text, called the Caring Text Study. I know this might be a stretch for these IT people in the room that might be thinking broader and bigger than this, but this is a capability that after somebody's been in, we have a therapy alone, therapy with text, and the groups are just running, and we're evaluating the effectiveness of those that get text during the week from their therapist that show caring outreach, similar to the caring letters study, I think, in the 70s, or even earlier than that, perhaps, 70s, where, believe it or not, when people know that people care about them, and particularly their therapist, but in the military environment, we'd like it to be their line leader or their peer, their friend at work, but when people know that there are caring outreach going on, they do better. And so this is a Marine sample, and it's being tested at a couple of our bases. I know Camp Lejeune is out doing quite a bit with it, and there's a couple other Marine bases involved too. So otherwise, we have our veteran military crisis line partners here, so I won't get into that because there's a lot of potential there, but know that we are all in as it applies to call center work and thinking through texting and chatting and doing therapy in an IT environment so that we can ease the access to care and eliminate barriers and stigma for getting people in the door. And otherwise, I want to close by sharing, like, if you're like me and you're thinking, well, what would the future look like? What would the future capabilities bring to bear around this space? I would just ask you, when you're doing your own thinking about this, to be reminded of the importance of peer-to-peer. So within the DoD, we have a strong public health approach that includes peer-to-peer models. So when friends help each other is when we know they do best in this environment, probably not like other environments, I would argue, but perhaps maybe even more so because the unit cohesion is such a strong protective factor for keeping people well. So IT capabilities that can embrace peer-to-peer would be beautiful and needed. Also, IT capabilities that can embrace what we've learned so far about social media and the existing database that I told you about, and bring all of that together in a more comprehensive way. This rich qualitative data that we have from what we're learning on social media with this demographic-based, variable-based, quantitative, massive database, and all of that together for a larger look at the issues would be helpful. Also, capabilities that lend themselves towards drill or rehearsal on how to engage on suicide prevention. But we know within the active component, the reserve, and the guard, they drill. They practice and they run scenarios. And we think that if they could practice scenarios tied to engaging with those at risk more frequently in a safe, structured way on how to ask, are you thinking of ending your life? How to practice it, how to get feedback on whether they did it right, if there was some capability that was tied to this rehearsal and drill idea, that would be helpful. And also, our data tells us that service members are going to their families first. So when they're most at risk and they're struggling, we have this status of forces survey data, again, available online. The results of this data are available if it goes to the dispo.mil website. But what the survey data tells us is there's a question on there, and they take a sample, but this is generalizable across the entire DoD. They ask the question, when you're struggling with fill in the blank tied to hopelessness and helplessness, all things you and I would know map onto suicide, where do you go for help? And we list all the capabilities known to mankind on the survey. And despite all of our best efforts to think that if we just plussed up mental health assets and we got more in the hospital and we got more clinicians and the like, where they go first is to their family member. And second would be to their friend. And so third would be to a chaplain. So thinking through what does that mean for our IT work, and are we bringing the best tools to bear across a broad continuum of care in the hospitals, in the community, with the friends, with the other gatekeepers, and really bringing a comprehensive approach across all would sort of, I think, be what the future might look like if you wanted to do some more thinking on that. So that's all I have for you this afternoon, and I'm happy to do Q&A at the end.
Yeah, thanks so much.
Yeah.
Thank you.
Great, thank you, Dr. Franklin. And I neglected to mention also, and you're going to hear from Howard Rosen of LifeWIRE in the context of a very cool communications platform a little later, and Mike Brand during the reception from LifeWIRE are also sponsors of the event. But what I've been thinking about sitting there, and as it happens, I'm hosting or doing a thing with the Case Management Society of America up on the Hill tomorrow. So I have on my mind continuity of care, case management, transitions of care, patient-centric care, and it occurs to me that just these speakers and more from the health systems could and should probably be engaged in, especially when you talk about families and religious institutions and the rest. And so the more that's got me thinking what a huge problem that is to get patients, especially these patients, into that kind of continuity. So with that, let me introduce Dr. David Carroll, who is the Executive Director of the Office of Mental Health Operations for the Veterans Health Administration. And Dr. Carroll implements, coordinates, monitors, and evaluates VA services focused on recovery-oriented outcomes, effectiveness, veteran experience, and manages a number of programs and efforts. And I'll let you look at his bio to see what those are. Thanks so much, Dr. Carroll, for coming over also. And we know you have to leave by about 4:30 or something also. So if you see him leave, it's not because he doesn't like
Great.
it. Thank you.
And I apologize for having to leave early. And in the interest of late-breaking news, actually, I am now the Executive Director of the Office of Mental Health and Suicide Prevention. So we one of the recent changes that we have made in the department under the leadership of the Secretary is to combine our mental health, suicide prevention, and our veterans crisis line teams into one effort so we can really speak and work very effectively with one voice. And I would echo so much of what Keita said in her talk. We work very closely with her office. We have done that. We've worked very closely with our partners at SAMHSA, Eileen Zeller, who was answering all the questions that Keita was asking in her presentation. But, so this is a tremendous partnership and with many of you and with thousands of others across the system. And I don't want to repeat things that Keita said. I'm going to highlight a few things and then also talk specifically about our mission and some things that are unique and related to telehealth. So our population for advancing health and wellness and preventing suicide are all 22 million men and women who have served in the United States military. We have a population health approach to suicide prevention. We have about roughly in the neighborhood of 8 million veterans who are enrolled in VHA care. On every year, about 6 million or so, and these numbers are approximate, are actually actively involved, and many of those, around 28%, 29%, are actually involved in mental health care. So you can see the scope of the problem that we're trying to address. We have a number of veterans who are in VA health care. We work with them very closely, with their families, but we're trying to address a population problem. Suicide is the 10th leading cause of death in the United States. This is not just a military and veterans problem, but it is a particular problem and concern for those of us that work in VA, for our DoD colleagues, and for everyone in public health. So we're really in this together. And therefore, we need community partners. We need engagement. Keita was talking about that transition from military service to civilian life. We know that period is a particular can be a particular stress point, particularly for those who may have had some issue or challenge while they were in service. We want to make sure that there's a continuity of care. The Secretary has also directed that we will provide emergent mental health care to those with other than honorable administrative discharges. So, we are looking, not just on those who would ordinarily come into VA, but really those who need care, and we want to be there for them. And that be there is the theme that we are using jointly between the departments and with our other partners, not just during Suicide Prevention Month now in September, but throughout the year. This is a campaign that we are in for the long run, and trying to advance that through social media platforms, through leadership engagement, through messaging in multiple platforms, and we would appreciate your participation in that as well. So the technology resources have to do with outreach. We want to make sure that there is low threshold for engagement, whether it's in care or whether it's connecting with people. I think looking at ways we can help veterans with the peer-to-peer connection that Keita was talking about in terms of staying in touch with their peers. We are actually working with a Marine unit now to kind of learn from them how they think they can be more cohesive, after their military service in a way that we can then, spread to other units. Part of our effort also is in terms of, looking at online courses, mobile apps. PTSD Coach was an app that was developed by VA. It's a resource. There are other apps that we have that support veterans work, whether it's insomnia, whether it's treatment for depression that are online. We're looking at online resources, so a veteran could participate in some kind of online therapy with online peer support when they may not be ready or they may not want to come into a facility for care, but we can still reach out to them. That's an area of growth. What I've been avoiding in my notes, and I'm going to talk to you right now, is what we do in terms of telemental health. And I have to acknowledge Dr. Darkins was really a pioneer in the whole sphere of telehealth for VA and nationally. And I think what we are doing, again, to make a very low threshold for engagement in care is in that whole sphere of telehealth technology. The Secretary and the President recently, demonstrated a VA Video Connect. This is a web link where a provider and a veteran patient can connect online through a web link, regardless of where they are. Neither one has to be in a clinic. They could both be in their own homes. And, we're working through all of the processes to continue to support that kind of, application, because we want to bring people into care if they need it. But to Keita's point, also in terms of we need everyone engaged in this, and I was really impressed by the comments about, the spread of this work across leadership in DoD. What we're doing in VA is what we call SAVE training, SAVE, and it stands for Signs, Ask, Validate, and Engage. And what we want everyone in VA, whether you're the person who, may park the car for the veteran when they drive up to the medical center, or the person who helps them check in, or serves them a meal in the VA canteen, or is their provider. We want everyone to have the basic awareness of how do you recognize someone who may be in a crisis, and are you comfortable? And there's role playing in our new version of SAVE training, so people can get familiar with asking a question and validating that person's response, and say, well, let me walk you to, let me get someone on the phone who could help you now. Let's do something together. So the reason I mention that is because I think that's a great opportunity for use of technology, because we certainly we're rolling that out not just within VA, but we want our VSO partners, we want family members, we want the volunteers who work in our facilities to have that training. Our veterans and military service organizations are very much involved in that work as well, and so there are opportunities there for spreading that training. In terms of telehealth, we have a system of regional telemental health hubs. Again, so we can, if you need specialized care for post-traumatic stress disorder or for depression, you can receive that regardless of whether or not there is a mental health provider in your local VA clinic. If it's a small clinic, you can get that care wherever, and that's an area of expansion for us. Two other comments, because I want to make sure we have time for discussion. Predictive analytics. Keita was talking about the dashboard, and I think that's an area that VA and jointly with DoD are looking at predictive analytics. We have a program that sits on top of our health system and administrative data that helps us identify people based upon what we know as unfortunately, prior deaths by suicide, who may be at risk because of life events, because of they've had multiple hospital admissions, or something has changed, multiple kinds of medication changes, problems that have been added to their list. This predictive analytics model will identify people who are at the highest predicted risk of suicide. And then what the system does is provides an alert to the provider to say, this person that you're seeing is in this highest risk group. The provider may not necessarily be aware of that just because it hasn't come up in the course of the conversation. And actually the individual patient may not necessarily be at suicide risk, but there are enough touch points, enough indicators in the system to say, you need to have a conversation, and that's the point of this. We need to be there for that veteran. We need to have the conversation and just say, how are things going? I have some information here that suggests to me that there could be some concerns. Are we doing enough for you? How can we enhance the care that you're receiving? And so I think that's another application of technology. We're continuing to refine that model. There's a lot more, but I want to mention one specific event here on Saturday, September 23rd. I'm looking to Leanne. That's the right date. We have a day of civic hacking, I think, scheduled, which is a day where a number of people who really are interested in data and looking at the data that we have, this information, and how can we better mine that data to understand what the risks are about suicide. And it's not just understanding risk, then we want to be able to do something about it, and that's where the technology may come in particular place. But also, how can we better share data? As Keita was saying before, I'm sorry to keep referencing you, Keita, but I think we work very closely together, and it's a great partnership, and it should be seamless, and we want it to be seamless. But how can we share this data repository better with people to help us understand that? And I think that's another part of this conversation that we're going to have on Saturday the 23rd, and we can certainly get more information to people if you have questions about that. Thank you.
Thank you. Thank you.
Thank you, Dr. Carroll, and to Leanne overall for all your work and helping to arrange this. When you work for yourself for 25 years and you have a couch in your office and you read a lot of boring policy papers, sometimes you fall asleep on the couch, and at the end of the couch is CNN on and MSNBC at all times, and you wake up and there's President Trump with Dr. Shulkin at the VA in a lab coat showing 10 or 12 different telehealth applications, and you think to yourself, did you die and go to heaven? Telehealth has reached to the executive office of the president. It was a great event. We're going to hear a lot more about VA telehealth efforts when Dr. Darkins summarizes a lot of this discussion and a little bit about what he has been engaged in over the years in just a few minutes. But first, we're going to hear a couple more speakers. Mark Newsom, who's the Senior Business, Financial, and Healthcare Strategist for IBM with an extensive background in healthcare management and finance. He's a 25-year-long, now retired Army Medical Service Corps Chief Financial Officer, who worked in liaison with the Congressional Budget Office and all of those kinds of things. I think that's your liaison office too, but for the VA, right, Leanne? I remember you folks when I was working on the Hill, long time ago. So in any case, I think Mark's going to talk a little bit about Watson and some other efforts that are going on within IBM right now. So take it away. Thanks so much.
Thanks, Neal, and thanks, Howard, for this opportunity to talk to you. So you're sitting there and you're wondering, what is IBM doing in this space? What can they bring to bear to help in such a critical issue for our veterans and our service members? So I want to just take a few minutes to share with you some of the technology that we are bringing to bear to help hopefully resolve some of this crisis. And our mission that we're starting out with is just to save a life. It's that simple. If we can get one, right, then we can move on to the other. But our mission is to save a life and allow technology to bring that to bear. So IBM has, in partnership with the Department of Veterans Affairs, has fused together several technologies to bring to bear in this particular place. Those technologies being chatbot, microbots, native apps, and also some of our IBM Watson capability. So as I go down through here, there are several things that I want you to sort of take heed to. And those who preceded me, Dr. Carroll and Dr. Franklin, talked to you. And if you looked at what they said, they talked about transition as being one nexus of point to be involved and influence the outcomes of what we're seeing. They also talked about peers, family, chaplains, and others that are there to help. All right, so what we're working on sort of gets right at the heart of some of those things. So some common things you'll see here. Digital representation of oneself, digital companion, self-reliance, social connectedness, and squad. So that peer, that family, and so forth. Our efforts go back to Secretary McDonald and the initial brain trust and what we started out to potentially get at PTSD and TBI. And through the course of that and our conversations with them following, we ended up at a point of looking at suicide prevention. And the question that we asked ourselves was, how can technology come to bear to help in suicide prevention? How can it help with the constraints on one-to-one provider-to-patient interaction? How can we bring technology to bear there? There are several fundamental principles that we settled on. As IBM, of course, we have clinicians, but we're not the clinicians. So we don't purport to be. We're simply bringing technology to an already proven environment of science and bringing it to bear to resolve a problem. You already have clinical practice guidelines, clinical protocols. So how do you infuse technology in that to bring to bear something that can impact veterans who are headed down the road to deterioration of a significant mental state? The second principle that we looked at was consumption. You have to present it in such a way that the user is entitled or desires to consume it. For most of us, that's our mobile phones. All right, that's the thing that's on our hip or somewhere most often. We also looked at early intervention, and we thought that technology perhaps is not the best place when someone is in crisis. So we want to get them early in the process, at that transition point to where they're struggling and they're looking for employment, or they're wondering what they're going to do when they're getting out of the military. So we thought technology was a better use as an early intervention tool rather than at the crisis point. And then we said it has to be of such a format that it's a digital representation of oneself. Technology whereby the individual owns and controls the data. They are able to mediate it to whichever environment and person that they want to. They're not beholden necessarily to the system, but if they want to share it with whomever they choose, they have that freedom, control, and latitude to do that. Once you have a digital representation of oneself, then we can move on to developing a digital companion. And I'll talk about that in just a second, to where we infuse in some chatbot technology as a digital companion called Chappie. And we'll talk about that. So through design thinking that we engaged in with the VA, clinicians, mobility experts, and other experts, we arrived at a concept called GRIT. It's a proof of concept around resiliency, both emotional resiliency and behavioral resiliency. We also learned through the process that isolation was one of those key factors, one of those precipitating factors to someone spiraling down and out of control. So we wanted to really reach them at a point to where they have that squad, those people that they trust, those people that if they were in a crisis, they wouldn't mind reaching out to them, and they wouldn't mind them reaching out back to themselves. We wanted to prove out in this proof of concept, how do you demonstrate that real-time, consistent collection of personal data could help a veteran understand and strengthen their behavioral and their emotional resilience, particularly during the transition from active duty to veteran status. It's built on technology that aggregates personal data into a digital representation of oneself, establishes a baseline of what normal looks like. So once we're able to ingest information into what our leadership allowed us to do and go back and do was to develop a trust platform. And that trust platform first seeks to understand the individual. What are your habits? What are your likes, dislikes? Are you one that frequents the gym? How do you like to consume information? If you were in crisis, how would you like for someone to reach out to you? Do you just want someone to push information? Would you want someone to call you, text you? So we work on understanding the individual first. From there, then we can ingest that particular information into this trust platform. It's secure, it's personalized, it meets all of the things that one would want. Then we infuse our Watson capability into that to evolve and surface intelligence out of that. Intelligence around where you are in terms of legal help that you may need, employment help that you may need, health or behavioral health help that you may need. Okay, so we understand the individual. We ingest it into a trust platform, a platform that the individual is comfortable with, that their information is secure, and that it's not getting out to anywhere that they haven't mediated for it to go. And then it's able to apply our Watson technology, which understands reasons and learns things that you ingest into it, and able to surface intelligence about the individual and connect them to services or help that they need. It's important to note right here that this is where the squad concept comes in. All right, so once we understand that individual and their information is ingested into the trust platform, they are able to set the parameters that they're looking for. They were to identify, who it is that they want as their peer in case they get into a crisis. Maybe you, Eileen, Dr. Carroll, Dr. Franklin, maybe those are the ones that I want when I'm in a crisis and not doing so well. So that is ingested into the information. It lives on their phone. The Chappie chatbot interacts with them and has conversations with them to set that baseline. And when they're outside of that baseline, then it allows the individual to either reach out for help, or it can automatically reach out to one of those peers and say, hey, we noticed that John hasn't been exercising recently, or they've fallen off from their normal behavior and habit. Maybe you ought to call them up and see if there's something that you all can do together. You all haven't been to the movies in a while, and you used to enjoy that. And so it can either prompt your squad, your peer group, or it can prompt you to reach out for yourself. The overall idea here is that the personal digital data is controlled by the individual, combined with simply designed technology, informed by proven science and clinical subject matter expertise, and it can help a veteran to be self-sufficient, self-reliant, and to cope with stressful phases of life so that they can live their most productive and best life. Chatbot is called Chappie. It's able to engage in conversation with the individual. So we, in our test phase, I downloaded and I had my son and go through it and sign up for it. And he was pretty amazed that he was actually talking to this thing, and it was learning what he was saying as he built his profile in there. So it's pretty powerful. So it can help with those aspects and social economic things of life that an individual struggles with: health, behavioral health, legal, financial, or employment. As a first step to our rollout of Chappie under this GRIT project, we chose employment as that first step. Because oftentimes, with me just coming off active duty only 2 years ago, and I sat through the transition assistance program, and fortunately for me, IBM had already felt that I was worthy to come work for them, so I was good. But there were individuals in there with 20 and 30 and or more years of service, and they were stressing about what they were going to do next. So we thought here as an initial proof of concept and test that we will lift up that employment aspect for Chappie to be able to engage with individuals. So right now we're connected with the USA Jobs, so the person that comes onto the platform, the trust platform under the GRID initiative with Chappie, and they're seeking employment. They engage in a dialogue with Chappie about employment, their skill sets, what they're looking for. Chappie is able to reach out to USA Jobs, Monster, or Indeed and offer up some possibles of employment for them to take a look at and apply for. It's our belief that early intervention builds the skills they need to find resources that can address their needs. Potential to reduce the triggers that lead to a downward spiral. So where is Chappie today, and where are we? We're at the point that we're ready to pilot it. We're still working with the Department of Veterans Affairs to get that pilot underway and to get it out there and hopefully save a life. And so the squad can be there. Thanks for your time.
Flag, either way on the back here. I shouldn't knock over the flag. It's not done. So thank you so much. Very cool. And that you can embed that many processes and intuitively, kinds of things. Technology is cool. Next we have, and it's a good follow-on, I think, to Mr. Newsom, is Howard Rosen, who developed the LifeWIRE communications platform in 2005, and who I've known probably since about that. He's been on our program many times. It's very interesting what they're doing. A small company that holds 3 process patents now, I guess, on sort of their approach to all of this and the analytics and things. I'll let you read about Howard. Dynamic speaker, speaks all over the country. Here for us, and come on up, Howard, and share. And there's some other LifeWIRE folks in the room too. You'll meet during the reception.
Great, thanks, Neal. No pressure.
No pressure.
Yeah, that's great. And I want to thank everyone, and very dynamic speakers, and of course, I want to thank everyone to have me rewrite my entire presentation during the presentations, having covered a lot of the key areas. So if you don't mind, I'll be sort of talking and reading some of my notes at the same time. Hopefully, you can pull it both off. And this is just for effect. I don't need them. The key thing is that everyone talked about, obviously, was the continuum of care, engagement, using the peer groups. The themes are very much strong and very much tied into what we do as well. And we've been honored. We've been providing services with the VA and DoD just over 7 years now in a number of areas, mental health, suicide in particular. And what I want to talk about in terms of, because you had a lot of key themes already on technology and otherwise, is some of the approaches that we've learned from that work over the years in terms of sort of the philosophies that are embedded into our platform, the technology that we do, and to see what is and why it is what we're doing, what we're doing. The thing is that when we're talking about innovation, fundamentally we also look at innovation is not just the toy or the technology. Innovation is approach. Is new ways of doing things, new partnerships, new ways of looking at the same thing. And we incorporate that quite a lot in how we do all these things. And we certainly particularly learned a lot in mental health and with suicide. When we first got involved, we almost had to rewrite our own book. It showed how little we knew, and working with our clients and the VA and the clinicians, learning new insights through all that, and to accept that there's new ways of doing things, and it's an evolving process. In many cases, it's the simplest things. It's interactions. What kind of language are you using? So it's speaking in a way that, in the case of the vets understand and want to listen to. In many cases, having the script and the interactions created by their peers. So a vet will respond much better to a vet than me, I can assure you that. Taking away the barriers, access to utilization of technology. Simple things like you don't have to download an app. The interaction just occurs. And allowing the vet or the individual to communicate any way that they want, again, instantaneously, taking away those little barriers as they exist. fundamentally, really what I'm trying to do, ultimately the philosophy is make it where technology is totally invisible. You actually never even see into the technology, just what you want to happens, other than the clinical side, the provider side, or through the vet themselves. It's sort of new realities that can be realized when you have real-time information being shared amongst individuals at risk, amongst their support team, amongst their buddies. Again, you mentioned squad. Big issue in terms of that peer side, in terms of sharing that information. And creating a continuum using clinical information. So, again, you hear a lot about transition. You maybe even starting earlier, and I'll talk a little bit about that, but at the transition phase and using all that information to notify, alert, engage, respond to those considering ending their life by suicide. It's all those pieces. So just to touch on more specific some of the ideas and some of the approaches that we're looking at is one thing, and you've heard touches on it again, is really development of early warning system that we've been working on. Is actually a continuum of that, starting from when you're in the, we're almost in real trouble there for a second. It's almost when you're in the field theater of war, and all the way through to you're finishing up your life at the DoD and through the VA, and if you get to a situation where you have a situation where is a suicidal attempt, but you don't stop the care there. It's continuing on through that to the entire, also the whole life approach. And again, we try to build our technology and our platform to accommodate all that in a simple and easy way, incorporating all the protocols that exist and allow the vet, again, to participate in how to change those protocols that make most sense for them. Ultimately, it's looking at, in terms of using multiple technology, let the vet determine how they want to communicate. It could be messaging, it could be wearables, it could be both. But collecting qualitative and quantitative data, looking at the subjective and objective insights that you're getting from them, and really creating, and again, to the point you're talking about, Mark, you're really creating a unique individual profile and creating that baseline and work off of that. So each individual, you get new insights, and from that, create new sets of interactions and be able to ask new questions on what they've given you in the first place. An important issue that's sort of talked about a lot is also to find ways to reach those who are not engaged by the VA and DoD. And again, as I touched on earlier, who are the 15? How do you engage those 15 who are not engaged by the system? And finding, again, developing approaches that are something that they want to do. And we've been developing what we call our in-reach programs, where individuals, vets, can actually self-assess. Using technology, one way is using keywords on text messaging. So, for example, if you were to text the word suicide risk to a shortcode, I'll share it with you later, that actually takes VA protocols that exist for suicide and best practices and actually operationalizes it through text messaging. Then the vet has the opportunity to self-assess, get a sense how they do, and give them the option for a warm handshake to a clinician, to a clinic, or not, and just do it again later on. But at least they're taking that first step of having that interaction. Well, having in the field, they've got to jump into the deep end of the pool right away. Similarly, using the same kind of approach to reach rural and urban underserved communities. They're right in front of us, and how do you access them? And so, again, our approach is, again, working for clients and using our platform to achieve those goals. And fundamentally, the technology really isn't worth anything unless it's being used, unless you earn the trust of the vet or the service members that have been disengaged through the system. And you got to get their trust before you get anywhere. And again, we're looking through providing the service and insight about what they want, how they want to receive information, what do they want to receive, with whom they want to receive it, when they want to receive it. They empower them in ways you can empower when you're in such an area where you can't empower yourself. You sort of feel overwhelmed. Take those elements and try to give them that sense of empowerment to, again, drive those next steps earlier on. And that's it. So at the end of the day, that's what we're trying to do. Those are the approaches we take and build into, and that's what we're working with the clients that we do to allow them ultimately to have this continuum of care, this continued connectivity, so they stay connected, the vets and members, so they don't self-isolate themselves. And that's it.
That's the least I've ever heard.
And we got a closet.
Seriously, get with all these folks in a few minutes after our last two, not least but last speakers. We'll have a little reception and beer and wine and things, and some interaction with the audience, and we'll do that while we're getting something to eat. How about that? Next we have John Draper, Dr. Draper, who's the project director of the SAMHSA-funded National Suicide Prevention Lifeline and Executive Vice President of the Mental Health Association of New York.
that's administered that program, I guess, since 2004. Has over 25 years of experience in crisis intervention, suicide prevention, and is one of the nation's leading experts in crisis contact center practices and technologies. And I hear his name repeatedly as we're helping to put these programs together. And then we've asked Dr. Darkins to sort of summarize everything at the very end. It's like the 4th of July fireworks, and the big finale that's going to be Dr. Darkins, okay? So John, why don't you take it away for a few minutes? Thanks for coming down.
Pleasure.
Yes. It's quite a privilege to be here with all of you and some very familiar good friends from SAMHSA, our funders, as well as our partners, the VCL and DOD. And again, with all of you, thank you for joining us. And Howard, thank you for inviting us. This discussion about what's the most effective way to reach people, starting with what they want, what, where, and how they want it, and getting care the way they want it, is really an important person-centered approach that we need to be taking forward in this evolution of a new healthcare system. And actually, I've had the privilege of administering the National Suicide Prevention Lifeline and its network of crisis centers since 2004, and working with the Veterans Administration, the Veterans Crisis Line, since 2007, which is really all about that. I mean, the crisis services in our national network, really in that crisis domain, has really always had the permission to get in people's lives 24/7 in a way that the bricks and mortar systems have not. It's allowed us to say, since crises have no schedule, when do you want to talk to us? And that's why we have 24/7 systems, basically a virtual emergency room, crisis hotlines starting 50 years ago, still very effective. And I want to actually talk, and Howard, I like the way you put it when you said, it's not about just innovative technologies, it's about innovative approaches. It's really thoughtful use of technology. It's not just a great new toy, it's how and where you use it in ways that people actually engage with it effectively. And so I want to talk a little bit about a very old technology which we have been using contemporaneously in really thoughtful ways, telephones, and specifically with the Veterans Crisis Line and that partnership. And I want to start with the Josh Omvig Act in 2007, which started with this notion of we've got to have a suicide prevention hotline for veterans. Now, this could easily have led to a national number for veterans, as well as a national number for the rest of everyone else. It would not have been unlike the VA to say, well, no, we want our own number. The wisdom of saying, no, what we need is one national number for all Americans, everybody in crisis, is proving itself to be extremely smart every day. And I'll tell you why. So the very first day that we launched the Veterans Crisis Line, veterans have been calling the Lifeline for years, and suddenly there was this press one option for them. I'm pressing that. So immediately we got veterans. Every time call volume goes up for the Veterans Crisis Line, call volume goes up for the Lifeline. Every time that the Lifeline gets more calls, so does the Veterans Crisis Line. Why? Because when people go on Google and they type in suicide, they get the National Suicide Prevention Lifeline number. And some of those people are veterans. They're not saying suicide veterans. They're putting, I'm thinking of killing myself. And then they get the Lifeline number, and there is a resource for them. When you ask Siri, I'm thinking about suicide, what do I do? They say, here's the Lifeline number. And if you're a veteran, when you're asking that question, it'll send you right to that same place. Now, here's something else that is a perfect example of the wisdom of this one number concept. How many people here know the #1 song in America right now? You're bucking for an apple, aren't you? You want an apple. You want one of those bright, shiny apples. Yes, you know. So the relevance of the #1 song in America right now, it's because the name of it is 1-800-273-8255. our national number. It's a song written by a hip-hop artist named Logic, which is actually short for psychological.
And you're going to sing a chorus?
We're all going to sing one. As he does, he gets everybody singing it. But it's a story of hope and recovery. It's a story of somebody who phones the national, who's suicidal, who phones the national hotline, and they hear the right thing from the counselor. And by the end of it, they're saying, "I want to live." And he has the whole crowd singing anthemically as one, "I want to live." So what we have seen as a result of this PSA that came out of nowhere is an increase in calls that's been substantive. In fact, Lifeline has seen an increase right now, 40% more calls this last August than we had last year. The Veterans Crisis Line, again, I'm getting back to the punchline here, the Veterans Crisis Line, because it is part of the National Suicide Prevention Lifeline number, a 34% increase in calls. So again, every time you advertise one, it brings in people to call the other. The other nice thing that we should be remembering, and this notion of one number is actually relevant here, just in this building. I believe there's last May there was a bill that was introduced, the Hatch-Stewart bill, that is relates to it would require SAMHSA and the FCC to explore the possibility and make recommendations around a three-digit national number like 911 for suicide prevention and mental health purposes. So that could be extraordinary in terms of access, increasing even more access to care immediately for people who are civilians as well as veterans and active military service. It could also likely divert a number of unnecessary callers from 911. But again, that we will just see whatever happens with that. But I find that, again, that the wisdom of that one number is something that we should really be proud that the folks at the VA made that decision. They said, that's what we want to do. And that's why we're partners. That's why SAMHSA has an interagency relationship with them, and why we have the privilege of working with the folks at the Veterans Crisis Line. Now, the other thing I want to mention here that I think is also very important is we've been talking about civilian partnerships between the Veterans Administration and the DoD. So how do we actually reach people in the community who are not being served by the VA? That 15 out of the 20 that are dying by suicide who are not engaged in the VA system. We know the VA does a fantastic job, a better job certainly than our mental health care systems in the community. So we either have to find a way to get more back into the VA, or we need to do a better job of getting our best practices in the community of care. So in many ways, this national network that we're running that are partners with the VCL may be among the most important civilian partnerships out there. If you remember the way the Lifeline is set up, it is a national network of local call centers. So what that means is that when you press 1, you get Canandaigua or Atlanta, and if you're a veteran, or if you don't press 1, calls go out to the network, and they go out to the nearest center to the person who's calling. So every one of these centers that is located in the community is potentially a veteran serving center. And in fact, many of them are. Those who don't press 1 will be routed to them, but that's only a small fraction of the veterans who they serve, those that don't press 1 on the Lifeline. All of our crisis centers in the national network operate several other lines, and they do texting, and they do chat, they do emails, they do outreach in the community. They are our tentacles and arms for suicide prevention, basically our suicide prevention army here in the United States. And they've not been fully mobilized to reach out to veterans yet. What we've really been focused on, so let me just give you the scale of this potentially. We did a survey of our crisis centers, and we said, we know that only about 15% of the calls that they take are Lifeline calls. The other 85% are all their local calls. So, essentially, we're going to answer about 2 million calls this year, the Lifeline is, and they're going to be answering well over 10 million. So, collectively, we said, well, are you serving a lot of veterans with your other numbers? And it turns out, now we estimate, extrapolated from the survey that we've got, but we estimate a conservative number of about a little over 300,000 vets that they would be serving out there that may or may not be connected to the VA, but they're at least connecting to them. So that means two things. One, we could do a better job, perhaps, of helping to engage them and engage the vets in better care. So getting more of our best practices out there. And by the way, this is the Clay Hunt Act that I'm describing. So for you, those of you who are not as familiar with the Clay Hunt Act, really what it does is authorize the Secretary of the VA to make sure that we have partnerships with nonprofit organizations that provide mental health care to reduce suicide prevention in communities. So that's what these organizations can do if we can do a better job of mobilizing them. So the next phase of our partnership, in many ways the partnership with the VA has been very focused these last several years on answering calls to the VA. We've done a heck of a job. I'll tell you, the VA has done a tremendous job, and right now they've pretty much solved that problem. Now we can look ahead to say, instead of just looking internally, how we can do a better job within the VA. We always want to do that. But also, how does the VA reach its arms and tentacles out into the community and engage these local crisis centers, for example, and help facilitate their engagement with veterans and with the VA. Essentially what we could be doing is creating tighter safety nets in the communities for veterans and everybody who needs care and who needs suicide prevention assistance, and then connecting that to our national network. So that is the next phase of our partnership discussions with the Veterans Crisis Line. We look forward to that. We've done a lot over the years in terms of working and providing chat support for the Veterans Crisis Line, and look forward to working with them in terms of extending other technologies. But most importantly, what we want to discuss with them and work with them, what we continue to hear from them, is how can we do a better job of just talking with people and helping them feel cared for. So look forward to doing more of that. That's a technology that will never grow old. Thanks.
Thanks so much, Dr. Draper. Very good. So Congressman Bergman has arrived. However, he does have a few minutes, he says, and so what I think we'll do is go to Dr. Darkins real quick, who's going to give us our summary, as I promised. Those of you who don't know Dr. Adam Darkins, he's a recovering neurosurgeon. Is that how I can? Okay. Who Brexited from England in 1997? That's right. Is that about right? All right, and retired from the VA almost 5 years ago or so?
3 years ago.
3 years ago. Seems like you've been gone forever. And but impressively, and if you were to look in his bio, you'd see that he put together a telehealth program around virtual services to more than 480,000 veteran patients per year. That's 1.4 million episodes of care, and on any given day, at that time, and I'm sure it's increased, more than 83,000 veteran patients were using home telehealth and related technologies to live independently and avoid institutional care. It's the kind of thing, and I've known Adam for 25 years through ATA and all sorts of groups, and when you think about it, it's proof that when you hold harmless at least some of the institutional policy barriers to telehealth around things like reimbursement, licensure to an extent, organizational buy-in, which doesn't necessarily exist in the civilian sector, that kind of thing. This is what we can do with telehealth and remote monitoring. So there's a lot still that health systems in this country have to learn from the VA and from DOD when it comes to providing telehealth services, and this is one of the guys who's probably got more of it under his belt than anybody in the country in terms of proof of concept. So Adam, why don't you take it away? When we talked on the phone, you said you'd be happy to be our summarizer in chief, so have at it.
Thank you, Neal. Well, good afternoon, everyone. Thank you very much. 2 quick disclaimers. The first is I've been doing some work with LifeWIRE, and the second is I'm a director of a company that does predictive analytics, looking at physiologic data to make diagnoses in mental health. I'm not going to talk anything about either of those two. It's my real privilege to be able to talk about telehealth, remote care, machine learning, and really how it can be applied to suicide and management of suicide. Could I ask quickly in the room, who knows anybody who's been in the military who's actually got bad PTSD? A fair number of people. Now, when I first joined the VA in 1999, I was in Phoenix at a vet center, and I was doing a cable TV show, and the person who was doing it was a vet who was in the vet center, and he was asked to interview me on his cable TV show, and he had quite bad PTSD, and the first thing he said was, "What would you possibly know about veterans?" Because British accent, and I wasn't a citizen in those days, and I was kind of there live on TV. And I said, you know, I come from Britain, and coming from Britain, my father fought in the Second World War in North Africa. He was fighting against Rommel, and he wouldn't be here. He wouldn't have been here, I wouldn't be here if it hadn't been for the US military. My mother lived in Liverpool as a child, and the river was bombed on one side, and she was on the housing side on the other. Likewise, if the US hadn't come into the Second World War. So I'd like to kind of start by really what this is about, which is the veteran. And I think in terms of the veteran, it has been the greatest privilege of my life to have worked for the VA. I mean, I think not just this country, but the world owes a debt to the veteran. So I think what we're talking about, and the problem, is how we address it. So in summarizing things and drawing together, what I'd like to talk, if I may, is not so much about the tremendous work we've heard, because the work is really amazing that's going on, but sort of what would it look like if some of these pilots, some of these initiatives were drawn together? What kind of vision are we looking for? And some lessons learned, I think, about what it would mean to scale it. Because really, it's great to hear about the opportunities, but in the end, we've got a sort of huge problem out there, and what concretely are we going to do, and when can we see the things all come to fruition? So I'd like to sort of draw some lessons, I think, in terms of doing that. So I'd like to say that I don't have a particular interest in the technology. I left clinical practice because there were problems in healthcare. So from my point of view, you approach this by what's the problem you're trying to address. So let me very briefly go through kind of 3 areas of telehealth that grew in the VA to give you an idea of what's the platform which is there, so what could be built upon. So when I joined the VA, the budget for telehealth was about $300,000, and when I left it was $450 million. And the money didn't really come from appropriation, it really came from solving problems in medical centres. So let me go through 3 problems. First was a problem in relation to veterans as they age with complex chronic conditions, ending up in nursing homes, and really a problem with how you face that. So in terms of doing that, the proposition was a remote monitoring program, monitoring those vets at home. And instead of going into the normal outpatient clinic, and if you go into the outpatient clinic, you might be seen every 3, 6, 9, 12, 18 months. Well, it happens that if you've got chronic disease, the likelihood of you actually having something at that moment in clinic is very low. It happens 2 weeks after, or sometimes 4 weeks before. So you could really say much of the way healthcare is currently constructed for certain conditions is just in case. We'll see you just in case. Well, it means that when you do get seen, when you've got a real problem, you have to earn your right by being an extremist. With your heart failure, you've got it bubbling up in the back of your throat, and you end up going on to an intensive care unit or maybe not surviving. So the proposition was to say, look, why don't we divert some of those resources and say, if we monitor people who are going to deteriorate over 2 or 3 days, and doing that we could pick up them before they were extremists, we could end up really being able to manage them much better. So we did that, and we saw 30% reductions in hospital admissions and bed days of care. We saw savings of $2,000 per patient per year, all costs including the program included. So also it was possible to provide care to 50,000 veterans, non-institutional care that prevented them going to nursing homes. So for me, simple problem, what's a hypothesis that makes it work? If you've got the hypothesis that makes it work, how do you test that out? Once you've tested it out, what are the issues around scaling it? So I could spend all afternoon, which Neal will be very glad that I don't. But it comes down to very logistical things like interoperability technology, standards, interfaces, training of people, and the rest of it. So it's really human factors that came in. 2 other quick things to sort of go through. One was a big problem around veterans with diabetes. Over 20% of veterans have diabetes. One of the problems with diabetes is sudden blindness that can happen. So we created a program that screened 440,000 veterans a year by teleretinal imaging, taking photographs of the back of their eye. So a very simple proposition again. Is there a need? Yes. If there's a need, is there a solution? So firstly, it has to be a clinical solution. What's the technology you apply to it? Then what are the business processes to make it work? Put it together, proof of concept, and you then scale it. And the last one I'll talk around is mental health. So in terms of mental health, in many ways, I mean, people don't obligingly turn up around a hospital when they have a problem. And for mental health, in the veteran population, it's very spread about, but particularly some people with major mental health problems. So really the solutions, and it's really important to have the clinic, it's really important to have the hospital, but how do you connect with people outside? So we grew a video conferencing system for the whole country to be able to do that, of which 90, 100,000 veterans receiving care. I published with my colleague Linda Godleski in 2012 the results of 98,609 patients receiving care between 2006 and 2010, with marked reductions in hospital admission. So essentially, there was an infrastructure in place that means for hundreds of thousands, if not potentially many more veterans, there's a way to provide care. And there are economies of scale once you've got this in place to be able to grow it. So, not wanting to spend a great deal of time, but what would be some of the lessons if I were to say, well, from what we've heard, what might that look like? Well, firstly, let me say, a challenge when you develop mental health services is how you address suicide. Because a certain number of people who come in for mental health issues will end up being suicidal. So you may think, well, this is very easy. You just put a video conferencing system one place, you put the patient in the other, connect the two, and everything is going to be fine. Well, it is a little more complicated. There are issues with state licensure to be able to make sure you've addressed. There are issues with liability. There's the issue about what do you do if it's actually necessary to then commit somebody. They're suicidal. How do you end up getting them hospitalized if that needs, and go through the legal proceedings to do so? If they are suicidal and they are in a clinic which is 200 miles away, and you are interacting one-on-one with somebody in a small clinic, how do you make sure that if suddenly they're telling you they're suicidal, you realize they're at risk or they're violent, how do you make sure you alert the rest of the clinic? How do you bring in the things to be safe? So a lot of this, the devil is in the detail. The vision of how one could end up saying let's video conference, let's do these things is relatively simple. So it was necessary to create all those kind of processes to go through and make sure there were standard processes and protocols to do so. The program I mentioned that was around monitoring people in their home with chronic complex conditions, many of them had mental health problems. So there was an infrastructure, but it wasn't the ability to be able to monitor people with technology. It's not knowing what their pulse or their temperature or their weight was. The real benefit of this was around how you coordinate the care. How do you coordinate the care of the patient? So there's a process in place to be able to do that kind of care coordination. And if you're monitoring people, you can then think about being proactive. The kind of predictive analytics that we just talked about from IBM, you're in a constant relationship. I therefore think that I will draw to a close, that really just to finish off and say, the issue is really about scaling. We grew the services at 20%, so I think one would look to both the DoD and the VA and really say, let's see the vision of the future, what it's going to look like, doing it at scale, and how we see numbers.
Thank you, Dr. Darkins, and again for your leadership. Thanks to all our panelists and for your service, and to the next gentleman who's our...
No introductions necessary.
Okay. Three-star former Marine general who's leading the charge on all these issues, and he's going to talk, I'm sure, for a second about his legislation that's pending with several other members, including Senator McCain. Congressman Bergman.
Thank you. They just called votes. That's what those noises are up there, and I'm sorry to have to, your schedule isn't your own. Even my wife now calls my scheduler when she wants to know what's going on. Nobody asks me anymore, they just tell me where to go. Of course, I'm used to that. But anyway, let me just say that as a member of the Veterans Affairs Committee and as a subcommittee chairman on investigation and oversight for Veterans Affairs, two things you need to know. Number one, the Veterans Affairs Committee is absolutely nonpartisan, or said a different way, it's bipartisan. We don't work, there are no party line kind of votes or, ideologies when it comes to veterans. It's about doing the right thing for the men and women who've allowed us to be here in a free society to be able to do what we want to do. So there's no question of what we're going to do or if we're going to do it. A lot of the challenges come with the how we're going to do it. And I would suggest to you, as we deal with mental health and the issues going forward with care of veterans or care of anyone for that matter, is that those of us of a certain age will expect to go and see eyeball to eyeball a healthcare provider. Many of you, as I look in the room at the age here, you don't want to be bothered with having to go see someone. You want it right on your device. You want your Fitbit to tell you what's going on, and you know what? That's okay. Because as we design healthcare systems, especially mental health care systems, that will take people out of harm's way. And that's what we're talking about here, out of harm's way, so that they don't make a very bad decision. As we design those healthcare systems going forward, the communications that we will use to take that person out of harm's way will change. Okay, and as we look forward, so to hear the word telehealth, I am excited about the possibilities, because when I wasn't in a Marine uniform and wasn't flying airplanes for Northwest Airlines for a long time, I've been in the medical field, operating room equipment mainly, but my understanding of healthcare and the needs of all, whether it's veterans or anybody else, means you have to stay at the very worst case even with the needs. If you get behind, it's tough to play catch up. So I applaud all of you for what you're doing. Know that what you have in this Congress is you have people who are committed to doing the right thing across, again, any party lines or whatever that might be. But if we can count on you to give us the ideas and shape it in such a way that we can form, whether it's legislation or policy, that cuts right to the heart of the issue. And I'm a Marine, so I don't waste a lot of time beating around the bush. It's let's get to the meat of the matter. What are we trying to do? What are we trying to accomplish? What tools do we have to do it? Or most importantly, what don't we have that we need? And here's the key. To anybody who's been in any kind of field for a while, what do we need to stop doing that no longer provides value to the outcome we're trying to achieve? That is the hardest thing for any of us. Think about anything that you might be doing in life, whether it's your personal life or your business life, that you say, I like the way I do this, but you know what? I know I really don't need to do this anymore. Okay, because that's where the real growth comes, in organizations and in treatments that will further the goals that we are trying to achieve. So thank you for what you do. I look forward to interacting with you as the time goes and getting updates, but I'm not going to quit on you, and I know you're not going to quit on our veterans. Thank you very much.
Thank you, sir, and to your office. And was going to mention it in introduction. Check out HR 2652, the Veterans Over-Medication Prevention Act of 2017, which Congressman Bergman introduced in about May of this year with a number of bipartisan co-sponsors, and then a companion bill on the Senate side, S992. He is truly the leader on all of this, and I think this panel is all of the ideas and some of the best folks in this country who could feed into that whole process on his behalf. Congressman Walz, who could not be here, Congressman Tim Murphy, and others who've led on mental health issues. And on that note, sad note, I also want to note, I don't know if any of you saw, Senator Pete Domenici died, former Senator Pete Domenici passed away, I guess, today. Another leader on disabilities and mental health issues when he was here for so long on the Senate side, on the Senate Budget Committee when I used to work up here. So with that, and not to end on that note,
Let's do questions and all, but let's get some food and something to drink and all of that and have a reception. I'm not sure how this is going to work, but someone lead it off. Sid, Wayne, Reginald, come on.
I'm actually interested in one of the things I heard about.
Stand up, say who you are also.
Reggie Humphreys. Had a friend at EHA in the Office of Research and Development who was doing an interesting pilot project developing technology in a wristband that had a lot to do with sweat detection and other sensors embedded, and they were looking specifically at the onset of PTSD episodes. I know this kind of goes far afield into the technology realm, but it seems like ORD, DIUX is doing some very interesting things with sensor for Defense Department and VACI too. And I'm just wondering if there's any of those cutting edge things that you can tell us about or point toward where you think there's some opportunities for bringing that technology to bear, the ecosystems that will translate into action.
I can share what I know, or if somebody...
I can share some stuff too. Why don't you go first?
Yours may be more relevant for this content area, but I don't know if any of you have heard of the Army STARS study. And so this is a biomarker, genetic biomarker study where they're looking at, I don't know that it's sweat, but it's other genetic biomarkers. And they pulled these biomarkers at key pivotal times leading up to deployment and then after deployment. And alongside that, they issued a number of scales, Beck depression, a number of sort of just evidence-based clinical scales to assess. And so they're mapping what they learned from the scale results with the biogenetic markers into a massive data set. They had originally started with Army STARS, and now they're expanding it across the whole DoD. And so far, there's 79 recommendations that have come out of that study, and they're trying to translate the recommendations into actionable policy changes for the services. So one might be about anger. I know I just took a brief not long ago from them, and they were talking about biogenetic markers that then coexist around periods of anger as an emotion, and then what we can do to make sure that we're identifying periods of anger as a high-risk period for our policies and the like. It was a small one that came out of the brief, but that's what I know. I don't know if you might have some other things that tie back to the biogenetic markers and the research and the tools around that.
Yeah, I mean, there's a lot of work being done. I mean, back to what I was saying before, really, one thing I didn't say was around evidence base. So one of the things that's really important about this whole field is we've got a chance to build things on evidence rather than the way the healthcare system has otherwise been constructed. That said, one of the things around evidence people are looking at, either can you look at mood, or the other really interesting thing is can you make some kind of predictive diagnosis? Because again, back to solving problems. One of the underlying problems in mental health care delivery is it's difficult to make the diagnosis. So it's not uncommon for somebody to have 2 or 3 diagnoses over time. So a lot of work is being done to say, are there some physiologic markers can help you decide, has somebody got major depressive illness? Has somebody got bipolar? And so that's very exciting because I think that unknown is one of the things that makes life very difficult because you're starting on this sort of vague trajectory. So that's the kind of work which I think is really exciting to look out for what's going on.
Mike Graham, just he's a chief growth officer.
A quick question. The 2 populations that we talked about, or heard you all talk about, that actually sound like they need more engagement. Let's say the 15 out of the 20 that are passing by suicide today that the VA does not see, but also knowing that females apparently are the fastest growing subpopulation from what I've heard. Can you comment if that's something that is from the DoD side as well as the VA, and how they're addressing those 2 populations that both seem to need additional insight or touch?
I can share what I know. I'll start with the female piece. This is an interesting phenomenon. You say it's a growing population, and I think you mean growing towards risk for suicide, right?
Yes.
Okay. So historically, anybody that works in the suicide space, we always say we have more instances of men that die by suicide than women, but we have higher instances of attempts by women, females. And then what we see is men use more lethal means, weapons, guns, firearms, and with the females in attempts,
prescription medication or other types of medication and the like, and less lethal, more opportunities to save and use capabilities, as you heard about today, to go in and save. But interestingly, you're absolutely right. So we're starting to see, I don't want to say if it's a trend, there are other experts in the room that can, just because trend has a certain operational definition that might be a little bit scary, but we are seeing more females in the DoD that are dying by suicide, and our active component anyways. And one of our theories about this is tied to Thomas Joyner, key researcher who has a theory about death by suicide, and part of his theory is familiarity with a firearm, and that those that die by suicide are more likely to be very familiar and comfortable and have less fear around a firearm. So if this were a firearm right here, it might make me a little nervous, like I've never really been around one that close. I don't have any at my house, and but a service member would just kind of be like playing with it and looking at it, and they would be okay with it and having conversation, holding it, and a female service member would be the same. And so they have increased likelihood to have one, to be around them, to have less fear of them. So there is a theory out there that potentially probably needs testing that says as you become more familiar and you have less fear of pain and less fear of weapons, more likelihood to have access to one. So one of our things we're trying to do in the DoD, we're using this language now, like put time and space between the person at risk and the identified mean. It gets tricky because it's not a Second Amendment issue, and oftentimes we've not done ourselves justice because we've used words like restrict access, which is not a good way of talking about firearms. Now we're saying put time and space between the person at risk, not everybody, and their identified mean. But it is a tough one, and so we think that that's why more females are attempting or completing suicide. Also, I think in the early literature, there's a whole line of literature about parenting, and parenting being a protective factor for suicide, and particularly parenting moms and dads. But there's theories too around no longer performing in your role as a parent, and so particularly females that might be removed from that role as a mother, and the implications of that for no longer feeling a sense of identity around parenting. So that's another piece of it. I don't know on the veteran side in terms of, were you all studying these female issues when you were as part of the VA or even since?
They certainly were doing. I mean, I think what's very exciting is to sort of see on both sides what's happening, which is around beginning to monitor data. Not to end up saying, because if you'd like, data is enormously important, but the data on suicide is kind of the end result.
Yes.
And so what's really exciting, I think, about what we're hearing is that if you work back upstream, it's a combination of things. Somebody doesn't necessarily just have mental health problems, they have other primary care problems, so it's a constellation of things. Plus, in addition to that, there's their family circumstance, there's the work circumstance. So to begin to monitor people, to begin to get, obviously with the bounds of privacy and other things, but to begin to identify when those stresses are happening. And then what are the interventions you can do to end up stopping people getting in that spiral? So I think that the area of monitoring we're hearing from both organizations, and the kind of work that IBM is doing to do that predictive analysis, I think that's really tremendous in terms of where this is all going to move and what we would see from both organizations.
I think it's just our experience, just like the female population. The female population is different from the male population. And the work we've done in VA, we sort of the extreme version of that, we actually worked out of Sacramento, is a maternal care program, which is combat-trained female vets suffering from post-traumatic stress who are pregnant. And there's about 1,000 women any day who are in that particular category. And there's actually, from the numbers that we're aware of, there's a 78% potential for a suicidal attempt in that population. And a lot of the issues, this is going to provide the tools for the clinicians to use our platform. It's providing them with the needs that their needs are very specific, and making sure they're getting those particular needs and addressing it, not how it's been done traditionally, but how it's needed for that particular population. So it's zeroing in on the needs for a population. We've been very fortunate in terms of results have been spectacular in terms of results of the group that we're dealing with. But it is a very unique population group, as there are many subgroups. Mm-hmm. And it's really more, instead of having these big whitewashes or everything treat this way, look at the subgroups as they are and deal with their particular issues going forward.
My
The other
apologies.
part
I had
of
to
your
grab a train. Great seeing you all.
The other part of your question was about 15 in care, 20, 15, 14. I've heard it different ways, and as a DoD employee, I should be hesitant to say too much about the VA side of that. Because Dr. Carroll left, I'll tell you what I do know about it in terms of what I've heard publicly the VA share about this. They're trying to study out who those folks are more, similar to what both of you are saying. Crawl all over your data and find out what you can in all of its richness in order to develop targeted interventions across. So who are the 15? They've been in a working group with Sam Eileen Zeller here in the red sweaters in the room. She's been leading that working group where she's bringing together the DoD and the VA with, like, the title of the group is something like Getting After the 15 Not in Care. Who are they, and what are the broader community solution sets that can be brought to the table for that group? So we're in the early stages of identifying that, and I know one of the things talked about is really like the goal might not necessarily be to get them into the VA care. It's to get them into care.
Right.
And I appreciate my colleague talking about the host of other issues that occur across the continuum, because when we look at our DoD data, about half of those that die by suicide don't have a mental health problem. So they have a life skills problem, a coping problem, a social skills problem, a lot of problems, employment, I heard. They have a host of issues, transition, but not always mental health. So if we have an over-reliance on one capability at the cost of a continuum of others, we can have a system designed for failure, I think. So, yes, ma'am.
I wanted to mention, I'm Cynthia Gilman. I'm with the Henry Jackson Foundation for the Advancement of Military Medicine. I run our Center for Public-Private Partnerships, and just wanted to make everyone aware that for the last 5 years we've been working on what we call the Better Metrics Initiative, and what we are doing is monitoring a cohort of folks who have just gotten out of service. They were identified from the VADER database, which is a mirror image of the DMDC database, and they're being followed longitudinally as they transition home. 3 VA researchers are on the team. They developed a well-being instrument, and they are looking across all of the different domains of well-being, the social relationships, vocation, which is education and employment, health and social. But we're looking for changes in well-being over time. Self-reported data every 6 months is being collected for a 3-year period of time. We'd love to see it keep going. We have 9,600 that came into the study, and we actually just shut the website down because we were too many people, which the researchers were not happy about that. But we're continuing to follow them. We are getting lots of data on them as they're experiencing this transition. And we want to make you aware, to the extent there's administrative data within the VA, they can be merged with this data set. So we could start doing some predictive analytics on this group that we are going to be seeing how they do over time. Love to talk through that.
What year are you at in your study?
We have just completed our second wave of data collection.
Okay.
So 1 year's worth of data.
Okay.
We have very preliminary baseline data, and it's now all being weighted.
Okay.
So it will be a representative sample across all services and guardian services. We have 1,700 women.
That's good. Thank you so much for sharing that. I think the military services might like to hear what you're learning along the way as well. So we should get together with some opportunities for you to share that with all of the branches in a formal way so that they're learning as you learn. Yeah.
And so Neal asked me if I would start to wrap up a little bit. We do have drinks and we do have food. We'd like to take one last question from the audience, and we'll try to make the responses brief as well, but then invite people to actually mingle and then talk with our panel of guests. We're very thankful that they've given their time today, but also that you all have participated. And I think more than anything, as we take our last question, it's really to also focus us on what's the way that we can use the best practices that we've already heard coming from the VA, we've already heard coming from the DoD, from the corporate world and others, so that we can really look at how we might join all of our forces together from best practices and from initiative and from really the spirit of hope to take suicide to zero. And so I'd like to ask who might have the last question. Sir?
I'm Shane Olson with Insignia Federal Group. I heard a lot about kind of transition from DoD to VA as being a critical point. We support the Transition Assistance Program worldwide and do the training. I need to check with the trainers. I think they do a little bit on stress management, but they don't really cover a lot of other spectrum of things from mental health to suicide. But I'm thinking that may be an area where we could at least insert some training and maybe resources, on both sides, etc.
It's a very good
throwing
point.
it out there as an idea.
Yeah. It's a good point, and you're onto something. Should be released at some point during September, but the DoD and the VA have developed an MOA to go into an official partnership and agreement between the two secretaries around suicide prevention and tightening the seams on transition, and that will be a forcing function for a transition working group to get stood up that brings together action officers from both VA and DoD to evaluate the training and think through refreshing the model with the newness that we're learning from the suicide field. So you're right onto the current issues that the two secretaries are trying to figure out too. But that's very good.
So we thank you guys very much. We would like to make this, hopefully, that we'll be able to have these type of engagements in the future. We hope you would join us again and even tell more folks, and so we can get to a cooperative environment of taking in these best practices. So I'd like to please give a warm thank you, a round of applause for our guests. And from us to you, I'd like to give you a round of applause, as this is all a team effort, so we're very thankful for you all. So please join me at the bar.